Good morning, everyone. I am absolutely delighted to be here. As you heard, it's my first time, and I'm going to discuss the treatment of the sequelae of acne. These are my disclosures. So there are three common acne sequelae that we all face. So first, there are patients with lighter Fitzpatrick skin tones who have well-controlled acne, but post-acne erythema that we also call post-inflammatory erythema. We also see patients with darker Fitzpatrick skin types, 4, 5, and 6. And those patients can have well-controlled acne, but have post-inflammatory hyperpigmentation that we also term acne-associated hyperpigmentation. And the final group that we see are individuals, they can be any skin type, 1 through 6, again with well-controlled acne, but with atrophic scarring. So we're going to discuss all three types. So let's start with post-inflammatory erythema. So this is erythema that remains after the inflammatory acne resolves or is treated. The hallmark really includes things like telangiectasias. You can see erythematous macules and patches of variable sizes. Now, this erythema will eventually improve spontaneously. It is due to the active inflammation, but our patients are not satisfied with the amount of time it takes for it to resolve naturally. We, of course, see it more commonly in individuals with lighter Fitzpatrick skin types, 1 through 3. We see the erythema, we see pinkness, but I want to point out that individuals with darker skin tones 4, 5, and 6, also develop erythema, but often it is not appreciated because of the melanin in the skin. Many of those patients also develop post-inflammatory hyperpigmentation, which totally obscures the erythema. Now, post-inflammatory erythema does present a great deal of psychological distress to these patients, and unfortunately, many insurance companies view it as cosmetic. It is far more than cosmetic for our patients. Although the exact pathway is unknown, we know that inflammation, we have various mediators, cytokines, angiogenic factors, and that contributes to neovascularization and angiogenesis. Also, with prostaglandins and leukotrienes, we get dilatation of the vasculature. And if you have thin skin, if you have transparent skin, light is going to be reflected, and you're going to very easily appreciate those dilated microvessels, as well as reflections off of the telangiectasias, and hence the erythema. In regard to treatment, there are no approved treatments for post-inflammatory erythema. There are a few very small studies with small numbers of subjects that look at topical oxymetazoline, topical bromidine, and topical tranexamic acid. What we need, of course, are large-scale, longer-term clinical trials to assess both the safety as well as the efficacy of these treatments in post-inflammatory erythema. So let's start with oxymetazoline. Here was a split-phase study of 3 months duration. There were 40 subjects who were enrolled, and they received 1.5% of oxymetazoline that they applied to the left side of the face for their post-inflammatory erythema, and it was compared to a placebo group. What these investigators found was that all of the patients showed significant improvement in their PIE on the left side that was treated with oxymetazoline compared to placebo. Oxymetazoline in a different concentration, 0.05, was studied and compared to placebo in 30 subjects. And this again was a split-phase trial. It lasted 8 weeks. And what they found was that there was a greater reduction in the erythema index in the group that applied oxymetazoline for 8 weeks. And no serious adverse events were reported. Let's go to bromidine. Here's a study, again, with 30 subjects who had PIE. They used a solution of 0.2%. It was applied twice daily for 4 weeks. And what they reported was that the erythema score had a gradual and statistically significant improvement during the 4 weeks of treatment. Topical tranexamic acid, 5%, applied daily for 6 weeks. Now, this was a compounded formulation, and the investigators reported that after 6 to 8 weeks, there was reduced erythema. And in fact, these particular investigators suggested that this might be a better option for patients who could not afford laser therapy. These smart investigators decided to put all of those agents together. So they combined tranexamic acid, 5%, oxymetazoline, as well as bromotidine. They used it in a split-phase study on 40 subjects with PIE for 3 months. The right side of the face is the side that received that triple combination, and it was compared to a placebo cream, and about 90% of the patients showed either good or excellent improvement with this triple combination treatment. About 20% of the placebo patients showed some improvement, which of course you would expect because the PIE is going to spontaneously resolve over a period of time. Here's a study that looked at timolol, 0.05%. This was an ophthalmic solution that was already on the market. It was applied to the erythema at bedtime, and again, they reported improvement after 12 weeks, and they noted that this was a patient with Fitzpatrick skin type 3. Now, various lasers have been used to treat PIE safely as well as effectively. Here's a study from the Chinese literature. They had 22 subjects. Please note that the Fitzpatrick skin types were 3 and 4, and these investigators found that after 1 session, the mean clinician erythema assessment scale decreased, and there was significant improvement in their subjects after 1 treatment with the 1064 picosecond Nd:YAG laser. Here you can see pretty dramatic before and after using the Vizia system. Again, 1064 picosecond Nd:YAG laser. Significant improvement in the erythema after 1 session. Here is a study with 16 subjects where they used the 755 nanometer picosecond Alexandrite laser. And in these 16 patients, again, with that clinician assessment of erythema, there was significant reduction after 1 month. And over 60% of the patients reported being satisfied, and 12% very satisfied with these results. Here is a study where they combined 595 pulse dye laser with isotretinoin in this particular patient. There were 5 sessions of the laser that were performed, and as you might expect, at the end of the study, there was significant improvement in both the lesion count of the acne as well as the erythema index. These investigators reported dryness, scale, and some erythema as adverse events. Now let's pivot and discuss post-inflammatory hyperpigmentation, also termed acne-associated hyperpigmentation. So this is hyperpigmentation that remains after the acne has resolved. And you will find that many of your patients come in and their chief complaint is not the acne, but it's the post-inflammatory hyperpigmentation. That's often their #1 concern. This is associated with decreased quality of life. These patients often attempt to avoid public spaces. They have poor body image. They have a diminished social life and perception that their disease is more severe. So, often we will treat these patients and they'll come back and they won't have one acne lesion left, but they have a lot of post-inflammatory hyperpigmentation. And they will say to you, oh, my acne is no better. So they confuse the two. And their main concern, as I said, is the hyperpigmentation. Clinically, it can be tan, it can be brown, it can be black, it can also be violaceous. And this occurs more often in your black patients. It's been reported in about 63% of black patients, about 52% of our Hispanic patients, and about 50% of our Asian patients with acne. Number one concern. So here are two women with hyperpigmentation. And with the red lesions, the red circles highlight the post-inflammatory hyperpigmentation, where the green circles highlight lesions of active acne that are hyperpigmented. So it's important to know that there's some patients with this persistent acne who have hyperpigmentation. So that's going to have therapeutic implications. Now, what causes post-inflammatory hyperpigmentation? Well, there are a number of mediators that are involved. There are prostaglandins, there are leukotrienes, and all of that does is it stimulates and triggers the melanocytes to develop more and produce more melanin. And that melanin can be in the epidermis, it can be in the dermis. Now, something very simple can have a profound impact on our patients with post-inflammatory hyperpigmentation, and that's cosmetic camouflage. It's very simple, it's very effective. There are a number of various color cosmetics that they can purchase over the counter quite easily, and some will find that color correctors, particularly utilizing a coral color, will help further mask that hyperpigmentation. This particular study demonstrated that using camouflage will not interfere with our acne treatment, and there was significant increase in improvement in quality of life in patients who camouflage their acne. And here are just some of the color cosmetics by a variety of different companies that are very effective to camouflage the post-inflammatory hyperpigmentation. And you can see that for several of these companies, they do have a wide range of shades that are particularly important for individuals with darker skin to match their complexion. So there was a Delphi treatment study that was published that involved 10 dermatologists who were experts in hyperpigmentation, and they made some general recommendations in regard of treatment for PIH, and they included to counsel the patient, of course, to avoid excoriations, that's a modifiable risk factor, to apply acne medications to the entire face so that you're treating that subclinical inflammation. Those patients who have hyperpigmentation, but if you palpate the area, it's raised, it's still active. They also recommended the use of sun protection, a broad spectrum, but also sun protection from visible light. And they said that we need to optimize the role of makeup and tinted sunscreens to camouflage the hyperpigmentation. So we know that ultraviolet radiation can cause increased pigmentation, but we've learned more recently that visible light plays a major role in hyperpigmentation, and it can, in addition, impede the resolution. So a broad spectrum SPF 30 sunscreen is not going to address visible light. What we need are sunscreens that contain a blend of iron oxides or non-micronized pigmentary titanium dioxide. And with the combination of those two, you're going to be able to reduce visible light transmission by 90%. And here you see skin types 3 and skin types 4. Both these patients have been irradiated with high energy visible light in the 400 nanometer range, and you can see persistent hyperpigmentation. And that hyperpigmentation can last 7, 14, 21 days. So it's critically important that we address visible light. In addition to iron oxides, we can use antioxidant-containing sunscreens. There's an antioxidant-containing sunscreen that has vitamin E, vitamin C, lycocalcone, glycerotinic acid, DESM, that are also effective in grabbing a hold of those reactive oxygen species that are produced by visible light. In terms of treatment, this Delphi consensus indicated that you need to treat the acne as well as the acne macular hyperpigmentation with a topical retinoid. And there are other agents such as hydroquinone, azelaic acid, and your retinoids. So all of your retinoids can be effective. They have the dual action of treating the acne and treating the dyspigmentation. They can be used alone or in combination with your azelaic acid, with your hydroquinone. And the real beauty is that your retinoids are going to treat that subclinical, persistent acne as well as the hyperpigmentation. Here's a study, a post hoc analysis of tazarotene 0.045 lotion, baseline, and after 12 weeks, a significant decrease in hyperpigmentation in our Black as well as our Hispanic participants. Here are some before and after, baseline, week 4, 8, and 12. Again, you see this beautiful clearing in the acne lesions as well as the post-inflammatory hyperpigmentation. Here's a very old study, it goes back to the 90s, that demonstrated after 40 weeks that tretinoin cream, 0.1%, was very effective and made hyperpigmentation either lighter or much lighter in the majority of patients. Be careful with your topical retinoids. Our skin of color patients can become irritated. That can lead to further hyperpigmentation. So you want to counsel them to use gentle cleansers, a moisturizer perhaps that contains ceramide. You want to help them avoid or counsel them to avoid harsh exfoliating washes. Azelaic acid, 20%, hydroquinone, 4%. They're very effective for treatment of our post-inflammatory hyperpigmentation. Hydroquinone is our workhorse at 4% concentration. It can be compounded to higher concentrations, but be careful of irritation. Cosmeceuticals. Cosmeceuticals work by a variety of mechanisms for hyperpigmentation. You can block the tyrosinase. You can block the transfer of melanin from the melanocyte into the keratinocyte. You can block the stimulation of UV radiation. Here's a combination of multiple ingredients. That's another beauty of cosmeceuticals that can all be put together and effectively treat the hyperpigmentation. Cysteamine, 5%, is new to our therapeutic armamentarium. This is an example of short contact is applied for 15 minutes with improvement. Chemical peels and microneedling can indeed be used. In terms of our chemical peels for our skin of color patients, we probably want to select our glycolic acid peels, our salicylic acid peels. If you use trichloroacetic acid, 10 to 30% only. Do not go higher unless you have vast experience, because again, the risk of post-inflammatory hyperpigmentation. On our patients with darker skin tones, you don't want to use medium depth peels, and definitely you don't want to use deep peels. So here's a study that looked at 3 groups, 3 different types of peeling agents, 35% glycolic acid, a combination of 20% salicylic acid and 10% mandelic acid, and then finally phytic acid. And what they found was that there was decreased post-inflammatory hyperpigmentation in all 3 groups with improvement in the hyperpigmentation. Non-ablative fractional lasers have been shown to be demonstrate improvement. Here's a study that looked at the 1927 nanometer non-ablative fractional laser. Here's the 650 microsecond 1064 ND-YAG laser. Again, improvement and tolerability in our skin of color patients. Now, in the last 10 seconds, atrophic acne scarring, very common in our patients. It can occur in all skin types. We know that there are 3 different types of acne scarring. You have your rolling, your ice pick, and your boxcar scars. In terms of onset, they can occur primarily from the inflammation, from the acne. They occur and form in the first month or 2. They can occur from papules, pustules, hyperpigmented areas, erythematous areas, from closed comedones, right? So it behooves us to treat acne as quickly as possible and as effectively as possible to prevent the scarring. Fractional laser and radio frequency are effective treatments, as are injections of high hyaluronic acid. Here's some very dramatic Canfield photographs. Subcision is effective, but radio frequency subcision is even more effective. Microneedling combined with laser, there are studies that show efficacy. One study here, very briefly, they looked at the difference between radiofrequency, microneedling, and laser and felt that they were equally effective. Here's the cross where they put trichloroacetic acid, 100%, and ice pick scars with beautiful improvement, but don't use it on your skin of color patients. And with that, I want to thank you. We reviewed the 3 major sequelae of acne and how to treat them.